usually online in the US and is available in other parts of the world. And then oral azoles like itraconazole or ketoconazole can have a role. And then there's some other more experimental medications as well. But the key is you have to treat this for many months before you can be sure that it's actually been killed, even if it looks quiet, because recurrence or incomplete treatment is common. And then potentially you may need surgery for various reasons, including if there's uncertainty, you may need a biopsy. And then corneal transplantation either as a therapeutic measure or if you have a perforation, which is actually a little bit less common than in some of these more virulent bacteria. So complications, acutely medication failure, you may need to switch around, or it may just be you need to stick around a lot longer. Perforation or need for a therapeutic transplant to remove the infection in block. And then chronically, these folks end up with a scar, which may require transplantation or hard contact lenses down the road. And then an interesting thing I had the wonderful experience of having with this particular patient last year is an entity called acanthamoeba sclerokeratitis. This is a bump, as you can see with this light. It is a little focal abscess or nodule, and it's debated heavily whether sclerokeratitis is typically an actual nidus of active infection or if this is an inflammatory response that's more like your typical immune-related scleral nodular scleritis. So it's treated as both at times, and particularly in some places in the UK where they strongly believe it's an immune-related issue. It's treated with immunosuppressants, including oral immunosuppressants. And then the other big issue is the recurrence, because these can stick around for a long time. I think we have a few minutes for questions. Yes?
Do you try and keep the IOP slightly elevated during or after a DSEC?
Yeah, so you don't want it to be elevated, but you want to have kind of normal pressure. So typically after you put the air bubble in, so the specific I didn't talk about, when you're putting that air bubble in intra-op, you actually fill the chamber. So you end up with a relatively high pressure for a short period. And this varies by surgeon, but typically if you're doing air rather than an expansile gas, you're going to fill the chamber to a pressure of 30 to 40 and sit there and twiddle your thumbs and look at the endothelium and talk about your weekend for 10 to 15 minutes while you give that pressure a chance to sort of give the initial adhesion. And then before you leave the operating room, since you don't want them to remain with a full air bubble and have pupillary block and high spike of IOP, you decrease the size of that bubble to slightly larger usually than the graft. So you probably don't want to have a low normal pressure, maybe in the low to mid-20s, somewhere around there. Because you don't want these folks to end up with a pressure spike, because that can cause problems not for the graft, but for the rest of the eye. But if your pressure is too low, then you won't have enough pressure to keep that air bubble up and keep the graft in place. Yes?
What's your opinion on cross-linking, and do you offer it?
We do not offer it here. Unfortunately, we do not have the resources to do it here. I have gotten a lot of referrals for early keratoconus patients that I have sent on to people to do cross-linking. I think the data is variable, but it looks like it works at least to help halt disease. I don't think it did what we thought it might do in terms of reversal of disease. But from anecdotal experience from people I know who have done it, it often will make people more tolerable of contact lenses and then can prevent earlier transplantation or potentially transplantation altogether. Others?
About how many patients they can believe would y'all see in their year?
You know, I don't know about here, but I would say in other places I've been, maybe a handful a year. It's not a lot. It seems like it often will come out in the spring. I remember we had like 3 or 4 cases in North Carolina in March or so across the course of 1 year. And they are not all super terrible. Most of them are pretty bad.
If you have time, would you touch on the treatment of Fuchs before you get to the surgical point of what you're doing now?
Yeah, so, you know, I think partially we're moving to earlier surgery with Fuchs because we have better modalities of surgery. But if you have a patient who's symptomatic from corneal edema with Fuchs, really our main options for treatment is going to be your hypertonic saline, so like your Muro. And for some of these folks, it's going to be typically, classically, it's more of an issue in the morning, and then it gets sort of better throughout the day as you're more exposed to air and blinking and eyes open. So for some folks, it may mean that they put some ointment in at bedtime to help, and then maybe throughout the morning use the Muro drops. But those burn, and often these folks also have dry eye type symptoms. So you might have them use the Muro in the morning and then switch to artificial tears if they are symptomatic of those types of symptoms later in the day, because often later in the day the Muro ends up not helping as much as just having been exposed to air for that whole time. And then some folks, and I've seen some folks actually do well with this. You can actually use a hair dryer to heat and dry the corneas. You know, it's important to counsel these folks that, well, here it's dry all the time. So maybe you don't for the people here, but in other climates where it's wet at a certain part of the year, like if it's more wet in the summer, the things are going to be worse over the summertime, and they're going to get actually better for these patients in the periods that are more dry.
The patient that developed the acanthamoeba, he said was not a contact lens wearer.
He was, but he had good contact lens hygiene.
So he'd never been in the water?
No, so
Did you ever establish another risk factor?
We never established like a particular source. Often you can. Often this is related to water exposure. And not everybody is a contact lens wearer, but it is a lot more common, and it's way more common for misdiagnosis in people who are not contact lens wearers, because that's your typical risk factor that everybody's thinking, okay, let's keep acanthamoeba on the radar.
You subscribe to the notion of keeping people on acyclovir for a year after the first episode of herpes simplex? It
varies. I am a big fan of prophylaxis, yes. And I would say actually longer than a year. A lot of these folks will end up for life. It would be an important discussion to have with a patient after their first episode. I would say I would coax a patient to do it after their second episode. If it's a first episode and it's epithelial only, it's relatively mild, heals without scar, I might consider waiting. However, if that patient has a history of immunosuppression, or if that patient has a history of frequent mouth sores that can be linked to or thought to be linked to HSV, then I would probably have them suppressive even from the first get-go. And then definitely if it happens bilaterally, usually that means they're immunosuppressed, but not always. And then if it's a bad case and it leaves a scar, I mean, I'd still have the conversation, but I would sort of coax the patient and say, you know, this can get bad. This scar maybe left you seeing 20/50. If it happens again, you might end up with scars that you're going to need a corneal transplant. As long as they're tolerating the medication, which most people do, And it's, you drop it down to a twice-a-day dose, which is a lot more manageable than 5 times a day, or just a once-a-day dose if you're using Valtrex.